Also, I think some sort of psychological counseling and boosting is necessary. So this tripod of this pain physicians approach these medications and intervention along with this physiatrist approach and so the psychologist approach. So because the patient is for the last 3 years is having this pain with depression, so 3 components are there. A multidisciplinary approach is absolutely essential. It is not that we pain physicians will be able to treat the patient, absolutely no. So we should refer the patient to our colleagues of other disciplines. So and this I think is necessary before going for more advanced techniques. Yes.
You are a neurosurgeon.
Yes.
Yes. If a patient is diabetic, having a tumor, intracranial tumor, so in that case, and having very considerable amount of edema, so in that case also we are using steroid.
And also
in this steroid, whatever amount we are using, that is very minute amount. It is not elevate your blood sugar level.
In a depot preparation, lipid preparation steroid, it will be there for 3 weeks. So very slowly it will come to the circulation, systemic circulation. So the elevation of blood sugar is not really a threat. So after this.
So even then you should take caution that
rather if you give short-acting steroid, water-soluble steroid, then there is a transient chance of increase of the blood sugar. But if you give long-acting, there is even less.
I think you have to compare the risk
And the
versus the
benefit.
benefit.
Yes.
Okay. So if the patient's going to benefit a lot, okay, then yes, go ahead and do a second or a third injection. If the first time you did the injection, he ended up in diabetic coma, you would wonder whether you really need to do the second injection.
Yes.
So it's always risk versus benefit.
And also, if again the patient is having, we agree that we will try 3 such injections. So then we'll say that yes, it start working, and if after 3 such injections, 3 epidural, this transfemoral epidural has been given, patient was comfortable for 5 months total. So after that, pain has reappeared. So what to do now?
Spinal cord stimulation.
No.
So first epiduralisis we will go for. If there is addition, we will go for epiduralisis. We will first do the epidurogram. We will see how much addition is there. We can go for rack catheterization, or we can go for epiduralisis even with normal saline. If the bleeding is low, we can do the epiduroscopy. If we fail in this, then we will go for.
Is there any opinion? Any other opinion?
See, that's why I said first time failed back surgery, radiating pain. Yeah, the debate is always between transbronchial and caudal. But if I did my caudal with a catheter,
Yes.
I get an excellent picture and I can tell whether there is scar tissue, where there is obstruction. So that I keep my picture at the back of my mind, and usually instead of just going up on your local anesthetic, if you use just your even enough amount of normal saline during the first injection, and you spread and do steroids well, in many cases the pain will be just better. So the first caudal helps you to get a good picture of the scar tissue. So if it comes the second or the third time, then you can decide, is it time to do lysis? So instead of wasting your third injection, if you already know that there is scar tissue, then you can, of course, in my part of the world, you have to have the insurance company.
So the consensus is caudal epidurogram to see where is the scar tissue is there. Depending on try to release those adhesions by hypertonic saline and hyaluronidase. And what percentage of the hypertonic saline do you prefer? Usually we get about 3% in India. In India it's not, because in USA they are getting more than about 10%. But we are not getting that here. Is 3% enough? So, or should we do it 3%? And should we combine hyaluronidase also?
I think hyaluronidase.
How much of this hypertonic saline is to be given? In each sitting?
You can do either 1-day lysis
Yes.
or you can do 3-day
3-day lysis.
of addition.
Yes.
Okay? The 1-day lysis that you do, hypertonic saline is very, very painful. So first of all, it's very important that you put your contrast, you check the placement of your catheter, because sometimes even though you think it's epidural, subdural spread occurs commonly after surgery. So you give a test dose, you take your catheter, you bring the patient out, because you want to give enough amount of quatapacin marcaine or lidocaine so the patient is numbed out before you start giving the slow hypertonic saline. Now hypertonic saline usually that we use is 10 cc's, but before you put the hypertonic saline, after you've given your lidocaine, you would use your Ydace or hyaluronic
Yes.
diluted
To soften the scar tissues.
soften the scar tissue.
Yes.
And then you can move your catheter in
Easily.
and around and try and remove the scar tissue as much as possible. But before you do anything, you have to be sure that you're not subdural.
Yes. So,
Can I ask one question?
yes, madam.
What is the evidence base about hypertonic saline versus normal saline in these cases?
As far as we know, there is practically both are equal.
Tonicity
So-
is not an important factor.
So, initially it was, yes, doctor.
So why do you
So,
use
initially
hypertonic
all
saline?
those attempts were with the hypertonic saline only, initially.
Now
So,
it's normal saline.
Now the people are trying with normal saline. So, but the thing is that there is no big difference, and the thing is that there is no RCT, there is no big studies, so only few case series, about 10, 15, 20 years like that. So, in either way, we do not know which one is better or whether both are better.
But I have a question to the hall about this thing. What is the adverse effect of this either hypertonic saline or normal saline this fibrinolysis?
I think that hypertonic saline, mainly it is irritation.
No, apart from pain, is there any post-operative, any sort of motor paralysis or sensory loss you have evidenced whoever doing this for a long time?
No.
Physiologically,
Recently I
hypertonic
come up with
Practically, in hypertonic saline,
yeah.
the idea is to put a less amount of volume. In case of normal saline, you can give 40 ml, 50 ml, like that. So, to break the adhesions. But in hypertonic saline, basically 7 ml, 8 ml is enough. And so, for a 3 days procedure, you put about 6 to 8 ml of hypertonic saline, and slowly for a period of not less than 10 minutes or 15 minutes, then you put the catheter, tell the patient to come secondly, because we think that because that hypertonic saline will draw the water and it will slowly, hydrodissection will be slow. But the hydrodissection is rapid if you put in a 1-day procedure with a large amount of normal saline. I think so. Do you comment?
What, in my experience, when I do my initial cardiac, whether it is the first time or the second time, I tend to use a larger volume of normal saline.
Normal saline.
So when I dilute my steroid or local anesthetic with adequate volume of normal saline, anywhere from 10 up to 10 cc's, in my hands, most of my patients are failed back surgeries, anywhere from 1 surgery to 7 surgeries. That's the collection I have with low back. So I find in my hands that I have to do less and less of lysis. And secondly, I happen to work with the guys who did a lot of lysis and a lot of publications, a lot of work. So if you ask them quietly, they will tell you it doesn't work for more than 6 months or 1 year.
Yes, yes. It's even not less than, even less than that.
Even
4
less
months,
than
5
that.
months are like that.
Yeah.
But it's better than transferable.
Yes.
Yes. So, this correlated with that.
in the fast sitting itself, as Madam was telling, caudal, epidural, and also transforaminal.
If you combine together,
because from the upward and downward, both can be accommodated in the proper space.
there is some idea, yes, Professor Durija was doing like that. Achha, okay, guys, sorry, you are telling something.
So what this large volume and is known to cause headache. I had a patient.
Yes.
Little faster than normal. Patient had severe headache and also is known to cause blindness because it was too much pressure.
So if the CSF sodium is increased, sodium content, so then temporary blindness is a possibility, papillaedema is possibility, the increase of intracranial pressure, CSF pressure, these all increases. So headache comes with a high CSF pressure and also that papillaedema, so temporary blindness like a TRP syndrome like that. So there is a possibility if you use high.
We have to be very scientific. Where you are injecting in the epidural space.
Yes.
Not in
Fetal space.
So epidural space, you are injecting a hypertonic saline, 5 ml, say for. So what is your mechanism that it will draw water from where? From the intravascular compartment?
No,
yes.
From the nerve sheets. The nerve sheets which are entrapped in the
from where it will attract water, absorb water.
Yeah, from
there is vascular vessels. The vessels are obstructed.
Epidural vessels?
There are vessels.
Epidural vessels?
There are vessels.
So intravascular compartment will be contracted?
Yes.
So should we do that?
Because the Halles is there also. The Halles also lyses.
And if you are giving epidurally, the most of the amount will be in the epidural space.
Yes.
Not in the intracranial compartment.
No.
It's not going to the...
No, that is accidental. Sometimes there is dural tear is there.
See, the other thing you have to remember, most of these are fake back surgeries. So sometimes when they have headache, maybe there is subdural spread. That's the reason why they have the headache.
So there is tear of those dural.
So then you have to give dye and see whether there is anything...
where it is going. Where it is going. Okay. Then what is the indication of spinal cord stimulator for this patient? Even if there is a reasonable or the patient, when we consider a spinal cord stimulator, as Dr. Paul was telling, that spinal cord stimulator can, yes, many people are advocating spinal cord stimulation. When we are discussing till epidural radial then when spinal cord stimulator is indicated?
When we have tried out the medicinal lysis, conservative management, and then we can give him a trial. Because he's young and he wants to go back to work.
Young man,
And another thing that is sympathetic denervation, whether it works for these patients or not. In the trial of sympathetic denervation can be done, that is sympathetic block, if we give this sympathetic block with local anesthetic, whether the patient recovers or some pain is